a lot of information that we're sharing right now. We have a really good presenter also at the end. We have a guest speaker that we invited to speak at the end, pretty much related to some of the members that you all coordinate services to. So I hope that it's helpful. Like I said, most of this information is either you will find it in the policies, or you could find it in the IGA that is signed with the tribes. And so it's not something that we go off topic. You know, we always try to stay aligned with what is the requirement. Of course, you all know the operational reviews are coming up too for some of you, and some of you have already gone through it. You know, those are some updates that we also provide here too. And then we've been having a lot of questions related to EVV, not only from providers, but we have members calling us. We have caregivers calling us, so we do provide that support also. So my team doesn't just do you know, prior authorization, approving higher level of care, but they're always pulled into other projects too. So it's a lot of work that we all work together here at ALTCS. So please take notes. Again, this presentation is recorded, so you can always go back and review it if you need to. Next slide. Next slide. Okay, there's a couple of policies that are actually our work group, our policy work group here at ALTCS is working on, and just wanted to give you a really high level review of what changes are going to be made. I know we've spent a lot of time, leadership has spent a lot of time for almost 2 years putting the 1620-10 exhibit 10, the person-centered service plan. We've spent a lot of time updating that, but it came back after it was reviewed by the NCQA, who is basically the it's like a committee that looks and reviews the quality of products and services, and making sure that, you know, these services are provided in an ethical way, and making sure that their members' needs are being serviced. So they did take a look at our PCSP, and they wanted us to update a couple of things on the person-centered planning to align with what is being required, what they're requiring us to do. So there is, like I said, a couple of updates in there. You'll see a much more in-depth in certain areas of that exhibit. That way you'll know what your case managers will be reviewing, and of course we'll provide more in-depth training once it has been approved by ALTCS. It is going to go through the normal process. For some of you that don't know the policy process, typically the work group works on it, and then it's sent to both ADs on the managed care side, and also on the fee-for-service side. Our AD reviews everything, all the policies, and then once they approve it, then it goes through public comment, it goes through tribal consultation, it has to get approved and by everyone. We all have to be in an agreement with these changes that are being made. So that, just be looking forward to that. There's going to be changes, and of course these changes have to be implemented by 10/1/23, which doesn't mean we're going to say as of 10/1 you should know this stuff. We don't work that way. We'll give you time to relearn. We'll provide more training on it. I would say, like with the previous one that we just did, we've been working on it for a couple of years, and the pandemic happened. We didn't implement that until last year in 2022. So with this, I'm anticipating it'll probably take about a year to really implement it at your level. So it won't just be here you go, you better make sure that your staff is doing this. It's going to require additional training again for your case managers in certain areas of that PCSP. So I'm just putting it out there to let you all know that there's going to be some updates made to that exhibit. As for the other two, it's just a really brief update. Like I did mention, you know, internally, we're still working on these updates. We do have to look at it on both sides, and I believe we're still reviewing 310P and 820. We're still reviewing those two policies, and it's just little minor updates that we're doing. As for the 310P, there's certain areas where we had to look at the time frame requirements, custom DMEs, and then also changes that will be reflected in the policy will also be provided to everyone before it's actually been approved on both levels. 820 also, there's prior authorization requirements. This is all related to the behavioral health. The majority of changes and updates are really for the behavioral health with everything that has been going on. I know that they did a lot of revision within 820. Some of these questions might impact those members that you all have related to if they're in a behavioral health setting. There's additional requirements that providers have to meet in order to get reimbursed for those services that they provide to our members. And then there's also an update that includes clarifying language for chiropractic services, dental services, add an IHS for 638 facility, laboratory services, requirements for AAC, which is more on the DDD THP side. And then also, you all know that we've taken over transplant. Division of Fee-for-Service Management has taken over transplant. So we have a team that will be coordinating services for meals and lodgings that will be under the transportation section. So there's updates that are happening, and these are just kind of the projected date. If it goes through from one level to the other of approval, first the work group, then the ADs, and again, it's out there for public comment and tribal consultation. Then if we get everything done, these policies should be updated. The projected effective dates would be 10/1/23. Yes, Diana.
I can't see the screen.
I can see it.
It might be on my end.
Yeah, you might exit out, Diana, and come right back in and see if that resolves it.
Okay.
Okay, thank you.
So as Cheryl has stated in here, it is good for leadership, tribal leadership. Let them know, whoever actually reviews if they're part of the tribal consultation, or, you know, have them please, you know, look out for those policies. If there's any questions or, you know, updates or whatever that you guys want to know more about, I'm pretty sure you can work with your leadership to make sure that they're advocating for you on these changes that will be happening. Of course, you'll have privy to providing those public comments to these policies on your end too. Next slide. Okay, the fun part here, case management operational review updates. Next slide. I know quite a bit of people have been different programs been very nervous about the audit. When we get there, you know, there's been how are we doing? How are we going to do? You know, you know, during the pandemic, things has happened, and on your level, we are understanding. One of the programs had said, you know, you guys were really gracious to us, and I seen this and I seen that afterwards. You know, we pretty much have the team pretty much has gone out a couple of review audits already. We have results or else they're putting it all together, combining and making sure that they're closing those out at the state level and providing a response to those operational review. Just keep in mind, this is across the board. the health plans will receive the random lists the day before they schedule operational review. We started that with the very first plan that we've audited, which was Native Health, and we've been implementing that across the board. So you will receive the list the day before of the audit. And then also the tribal programs must respond to the OR utilizing the CAP form. We usually provide a CAP form to you all when we're doing the operational reviews. So if you could utilize that CAP form and provide it, get it back to us by the close of business outlined in the operational review results letter. So just keep that in mind. Whoever is going to be working on providing that response, typically it's the leadership, whoever oversees the program, they will be the one responding to these operational review response. So in collaboration with your team there at the plan level. So please keep that in mind. There will be dates on that letter. Utilize the form. Many of our current tribal ALTCS, either supervisors or case managers, are very familiar with those forms. So utilize them as a resource. Of course, we're always here to provide that support too if you need us to walk you through something. I know we have a couple of new leadership at the program level, so please don't hesitate to reach out to us and we can help you to complete that form. And then as for I guess this is where the nervousness comes into play, like when everyone's nervous, I don't know how we're going to do, this has been happening. We get all kinds of comments, before we go out to do an audit. This is where we've always said over the years, we do have the quarterly supervisory audit reports. If you have been doing that, if you have been reviewing your staff's work at your level, as a leader, you should be able to identify where the issues and the barriers that you've been having throughout the years and letting us know, hey, we need help in this area. Because my team is really looking at those and making sure that if there's any support that you guys need, I mean, if we're getting these supervisory audit reports with 100% all across the board, we're expecting by the time we go out there, we're going to see 100%. So you have to be really honest with yourself and also be honest to, with your case managers and really work with them and if you're seeing issues in certain areas of a standard, please review it with them. Please let them know that, there's areas that you all need to improve at your level, because it is the program's responsibility to utilize that form to their advantage to make sure that your program, you as a leader, knows how your program is working, where's the issues happening at, what type of deficiencies are you seeing across the board with the case managers, and what type of support do you need to provide to your case managers. And if you're brand new, you're not familiar with something, like I said, you always have, you can always reach out to one of us and we'll be able to set something up and walk you through whatever you need help on and guide you through so that you can be successful on providing that leadership support to your team members at your level. Next slide. Next slide. This presentation is related to EVV, the EVV process, because we've been getting a lot of questions related to EVV and where we were told, we're not getting the prior authorizations, they're not getting updated, we're rendering services, this is coming from the provider, or a caregiver would call us and say, I can't work because my agency is not setting up these schedules, because they have to have like a schedule in order to clock in and out. That was the whole thing with EVV, was to ensure that our members are receiving the services in the community. Even though we're not there physically, they all have a system in place to make sure that these members are, their caregivers are clocking in, clocking out. They have a list of tasks that they have to complete at the end of the day. Usually that comes from the referral that is sent over to them. So how it starts is it starts with the case manager's review. And after the review, they would enter services into PMMIS. After it is entered into PMMIS, everything just kind of works really quickly in our system. Not only is our PMMIS screens updated, but also the SunData system is also updated. And then also our provider portal online, that is also updated for the provider. So all of these three areas, the EVV, the PMMIS EVV PA table is updated with that authorization within 24 hours after the case manager enters. Then the provider portal gets, that one is instantly. Once they put the PA on the CA 165, it'll update the PA portal for the provider portal for the provider. They'll be able to see that PA in there. And then within 24 hours, it'll also update the SunData system. So the provider has to check two systems. They have to check, make sure the PA is in the portal, which is where they bill from. And then they also have to check the SunData system to make sure that PA is there in the system. So it's really, really important that the case manager be updating these PAs as you know, within 5 days after the review has been completed, because that allows them, the provider, to render services. And then once that happens, everything has been updated, all systems have been updated. Then once they see the PA is there, the provider will set up the schedule in the SunData system when they receive the referral. The direct care worker will then render services. There will be a schedule in there based on the referral. There'll be a schedule in the system for the member, and they will then utilize the device. Some providers are still getting the device right now. Not everyone has a device. Some of them are still using paper timesheet, but we are asking them that they make sure that they get the key fob for those members. So we're really encouraging that, and it's coming along. Not everyone has been on board. We're still communicating with SunData, so that's kind of where we're at, making sure that each of our members have a device, either a fixed device, a mobile device, or if they're using telephony, they're using that too, along with the paper timesheet or the fob. And then once the direct care worker renders services, member would then, once it's in the system, member would then go and verify the services has happened. They will make sure that they're signing off on what the provider has rendered to them, and that information will then be sent over into the SunData system. Once that happens, providers are really getting good at this too, to where they verify visits as it's happening throughout the month before they bill. So they know that the workers out there, they're rendering services. If they have a device of any sort, or if they're calling in, it'll actually, with the fob, it'll give the GPS location. If they're using the mobile device, it does the same thing too. So we will know where this caregiver is clocking in and out at. We're able to see that. And once that all happens, Access DFSM claims will then go into the system. Once they get the claim, the system will automatically go its regular route of claims editing. It'll trigger if there's something missing. It'll trigger if something is missing, maybe units, dates of service is not correct. It'll let the provider know whether the claim is going to be approved or denied. So that is kind of like high level view of how the EVV system works. Next slide. So this is what I was talking about. This is what the case managers do. As you can see, I may be a little bit too small down here, but when you take it back and open it, you'll pretty much, most of you know what the screen is. Below is the bottom one where I said where it all starts at with EVV. I didn't want to make that too big because we're all pretty much familiar with that screen. So in this particular case here, this case manager has actually entered a service in PMMIS for is it S5125, and with a U5 modifier from 7/1 to 7/31/2023 with 620 units. And they modified that. They made that medical needs determination date on 6/22/23. So once they enter that, as I said, remember 24 hours, it's going to be posted on the EVVPA table. So this is our NPMIS. You'll see where the first arrow is. The 6/22/23, that first box there, the service assessment date, that matches that date. That lets us know when the case manager has updated this service. And then also on the other side, it lets you know how many units. That matches the PA screen, the start date, the PA max, the start date, the end date. And then down below, you'll see record add date. That's actually been added and uploaded to the SendData system. So sometimes it takes a couple of days, but depending on what's going on, it'll update it. Or if there was any revision done, it will wait until that revision has been completed by the CM before it actually updates that PA for you. Oh, actually updates the PA in the EVV table on the PMMIS side. So it's really important that your case manager authorize these services before the provider renders these services, because if dates are off and they're trying to submit a claim, it's going to deny the claim for the provider. So make sure with this particular one that I pulled, it was authorized all the way to September and everything was good. They shouldn't have any issues once they submit the claim for each month. And they also put the PA in there, way before 7/1. So we know when this provider will see it, it's authorized, they'll be able to deal without any issues or questions. Anytime there's changes, our system lets us know when the case manager is entering anything in PMMIS, and it'll give us a tracking mechanism. So case manager may say, yeah, I did that already, but they call me again. But when we go back in, it'll have different layers of how many times that service line has been modified and when it was adjusted. So please make sure, let them know that they need to make sure that these authorizations are prior to services being rendered, because it's going to hold up payment at the provider level. Next slide. So I believe this is my last one, so I'm just going to quickly
Rachel,
run.
Annie had a question. She said, what PMMIS screen? This is, I'll let you go ahead and answer that, Rachel.
Oh, as for that EVV screen, that's more at the access level, because we monitor the providers. We monitor the providers, so the case managers don't have access. It's a claim screen. Okay, so as I kind of briefly said over, this is what happens in the system. This is SendData's system, and I'm not really going to elaborate on any of those at the bottom because I kind of went over that already. The top screen shows what it looks like. I know case managers have questions. You all have had questions and said, how do we know this visit happened? How do we know this provider is rendering services, right? So this is the SendData system. The very first top box is the SendData system. This provider is really good at verifying visits every day. She would go into the system. She makes sure that all tasks were signed off. There's another screen that they would have to review, and they would see that the member had signed off on that service. Once they do their part, whoever is the administrator on the provider side, they will go ahead and go through, make sure all the tasks were completed, make sure that the member had signed off on it, and it'll give the case manager, give the administrator the ability to know where that person clocked in and out at, making sure that that's correct. Once they do all that, they will then verify. As you can see, you'll see the next one above the first, the way bottom one says verified. That tells me that whoever that administrator was went in there and verified everything in that screen for the service that day and said everything was signed off, and they verified the visit happened. And then then the next day, of course, that was yesterday, I believe, that's incomplete. And the red dot right there that you see for that day where it says incomplete those are the exceptions that they have to clear out. If there's any red dots in there, something is going on with that visit. They either didn't clock in or clock out, or maybe something happened with the device and they weren't able to do it. So it'll let us know right away. If they manually change something, it'll let us know. But if everything went through, the worker did what they had to do, there would not be any red dots there. It will let them know. In this particular case is when I captured this, the caregiver had just clocked in. They hadn't clocked out yet. And that's the reason why there's a red dot there. So once they clock out, then it'll remove that dot. But if there's issues with the clock out, then the administrator would have to make sure those are cleared out. And then the next level you see is a schedule. That's how a regular schedule looks like before any service is rendered. So that's how we monitor the provider at the state level to make sure that our members are receiving the services that they're getting. So it gives you guys all a sense of peace and ease that this member is receiving services. Even though we're not there to see it, the system is actually allowing us to see that these visits are happening. We also know if there has been an adjustment made. So those are the ones that we really look out for, and we start asking questions. Why are you adjusting this time? We need to see what you're doing. Why are you adjusting? You should never be adjusting time at all. And we've been hearing, because we don't have a device yet. Okay, now I need a ticket number. Have you submitted a ticket number to send data? We need to make sure that you're using a device. You cannot be using paper timesheet too long. We need to make sure these visits are happening using the device that's provided by Sendata or your alternative vendor. So we're pretty much monitoring this very, very closely on a weekly basis. We are monitoring this to make sure that providers are rendering the services that they agreed to render to the members that you all have at your level.
Hey, Rachel, in
Mhm.
regards to what you had said, some questions have come from supervisors about the paper timesheets. And we do know, I just want to clarify for those supervisors who have had those questions, that if they're using an FVV device, then they do need to have a paper timesheet.
Yes, FBB or telephony, either one of them, because sometimes the phone, it drops calls, sometimes they lose connection. And just to be on the safe side, we've been telling the provider, you need proof in the event that Access asks you for it. You need to have a proof that the services were rendered. Yeah, so on those ones, if you let us know which members, we can probably look it up in the system, Sharon. If you could just send me a list of those members, and I can do an outreach to the provider and find out why they're still using the paper timesheet. And that could only be because they submitted a ticket. I know the FVV devices were on back order. I know the providers have also tested the mobile device and they're not working in certain areas. So we do need to make an outreach. So if your case managers notice that the member does not have a device, always let us know so that we can do the outreach to the provider to find out why they're not using a device. Next slide. I believe that's it for me. Thank you so much. If there's any other questions, please don't hesitate to contact me on the presentation that I've made. If you need more clarity or if you want to meet just to discuss some of these, I'll be glad to do that. I don't want to hold up this meeting. We have a packed agenda. So if there's not any more questions, I'll go ahead and pass it on to the next presenter. Thank you very much, everyone.
Okay, and this is Sonny Fisher. I am going to go over A couple of topics, respite care, which has come to our attention, and the policy. This has been a very big issue for the agency, and actually throughout the state. It's just a very big issue is respite care, along with some behavioral health codes that have been used by behavioral health providers. And a lot of you have seen some of those providers who have had been terminated or have been placed on just there's all kinds of issues going on. So we are really monitoring this very, very closely. And the other thing I'm going to go over is transplant cases. So go next. And on the respite care and policy, next. Okay, so respite care, to really kind of dig into this, what does the AMPM policy say that respite is to be used for? And it does say, so if you look at AMPM policy 1250D, as in David, it states that respite care is to be used as an interval of rest and or relief to a family member, which would be a paid family member, or another individual, if it's not a family member, caring for an ALTCS member. And they provided the link to the policy right there. And again, a snapshot of the actual policy where it states what it is to be used for. So next. So if a primary paid caregiver is needing to take some time off, they need a break for a few days or a week or a couple of weeks, then respite can be instituted. And that would be in place of, not in addition to, attendant care services. So respite is to help the caregiver to avoid burnout. And that is a real thing for caregivers. We know that. So we're very conscious of that, and that would be an appropriate use of respite care. Maybe the caregiver needs to take a vacation, or there could be any number of reasons why they need to take a break. But it's very real. There are some policies that we are working on that have to do with making sure that we avoid burnout, because that is so real. So again, respite is not to be utilized as extra attendant care services. So if a member really does require additional services, say over a period of weeks or months, then that should be used as attendant care, S5125, not S5150. And if that additional services moves the CES to between 81 to 99%, then a CES packet must be submitted, and our coordinators will review it. And if it's approved, they'll let you know. Then if it exceeds 100% or more, then the CES packet has to be submitted to Access, our clinical nurse, to review. Next. And the policy does state that the combined total of short-term and or continuous respite care cannot exceed 600 hours per benefit year. And the benefit year is defined as a 1-year time frame from October 1st through September 30th. And also I provided a link in AMPM policy 1620C. And if respite is used in a repeated pattern, such as weekly, and it says that right there, you'll see down below in the snapshot, it says respite if provided in a repeated pattern, such as weekly, then it must be included as part of the cost effectiveness study calculation on the CA 160 screen. Next. Okay, so on the scenario, below, this is what if the CA 160 would look like. And let's say if a member has S5125, which is attendant care services, but the caregiver is going to take or have additional services. They need additional services, then it would be, and maybe there's another caregiver unrelated to the member, so there's no modifier in there, then this is what the CA 160 would look like, is they need additional services. But in this case, in this scenario, if this happens, the PCSP and the H&T should reflect the entire number of units. And they should explain the medical issue that's going on with the member. Why do they need these extra services? That's really important. And this is, something that we're really watching very closely, again, because of the number of abuses that have happened throughout Arizona. Next. And the case manager would need to submit a CES packet, again, like we already said, if it's over 100% to the clinical nurse to be reviewed for medical necessity. And they would need to indicate when are those services expected to be reduced. So it's, once again, cost effective. In this scenario, the case manager would have to submit the CES to the clinical nurse every 3 months if it's over 100%. And with each update, or with each submission, they would have to put an update as to what is being done to reduce the attendant care services, so that, again, they can be cost effectiveness to keep the member at home. And in that scenario that I showed on the previous screen, it would mean that it's no longer cost effective to keep the member at home. So therefore, the family would need to figure out, so what do we want to do? What do we need to do to make it cost effective again? Do we need to bring in some informal support? Do we need to, what is it to help bring the services so that they're cost effective again, under 100%? Or do they have to make that really hard decision to move the member to a skilled nursing facility? Because at that point, that's where this is headed. Next. And so a correct usage of respite care on the CES would look like this snapshot that I provided below. So in this scenario, let's say that the paid caregiver needs to take a month off to go on vacation with their children. They've been working nonstop and they're exhausted, and their children need some attention, so they need to take some time off. So in the CA 160, it would reflect S5150, 5150 for the first month, and then S5125 for the second month and the third month. So you can see here, it shows it would be at 77%. On the previous one that we showed, it was at 143%. So next. So again, to talk about the difference between respite and attendant care, respite is to be used as an interval of rest and or relief for the family member or whatever caregiver is taking care of our long-term care member. And it's also aimed at improving the emotional and mental well-being of the member as well. And again, there's the link to the policy. And attendant care is a combination of services which may include homemaking, personal care, general supervision, and companionship. So this is to help keep the member at home versus going to a nursing home, which is our last case scenario. We really, want to try to avoid that at all, if at all possible. And again, there's a link to the policy. Next. Okay, and in addition, so ALTCS has, as we stated earlier, ALTCS has implemented a restriction on claims submitted for respite care that contain 8 or more units due to the recent behavioral health issues that have arisen. And I know some of you have brought this to our attention. Providers have brought that to your attention. And Rachel and I have done an extensive research into this, and we have determined that yes, that is appropriate. So if a member has respite care in conjunction with any of the behavioral health codes that were reflected on that snapshot to the right, then the provider must submit, as it states there, a copy of the signed general and informed consent to treat, the most recent comprehensive assessment, the treatment plan, and the medical documentation for the services billed. If the member, yes, we are able to track respite care through EVV. Rachel just posted that. That's absolutely correct. We run into this just recently. So if respite is provided without any of those behavioral health codes, they are again any respite services of 8 or more units per day. The provider must submit the referral that the case manager sends to them for the respite services that states what exactly this the caregiver is going to provide, and in addition, the medical documentation for any of those services. Next. Okay, and I'm going to talk about transplant cases, and then if you guys have any questions, we'll talk about that next. So if any of your case managers, you or your case managers hear about a member who is going to be requiring a transplant, it is really critical that you guys notify us. Regardless of whether the member has Medicaid access primary, Medicare primary, or has a TPL, we need to know that. The reason why is last week it came to our attention that our tribal ALTCS member just received a transplant in July. We became aware of it after the member was released from the hospital, after the transplant procedure, and they're in an apartment. And unfortunately, the family's member had to foot the bill for the first week of lodging and meals. And had we known in advance, we could have helped alleviate that burden from the family by helping to pay for the lodging and meals. So this was really unfortunate. But we want to make sure that if you guys know of anything, please let your coordinator, let me, whoever. You really should be letting your coordinator know immediately. They will notify me and Rachel, and then we can get started on this right away. Our clinical team has to be involved. And I've provided a link to the policy. Yes, Casey, go ahead.
Oh, yes, good morning. Can you hear me?
Yes, we can hear you.
Okay, good. I was on a private caller earlier. I was
Okay.
on my way somewhere, and now I'm set up. So, but on this transplant, I know in the past, prior, it wasn't a service that was, or the meals and lodging for long-term care. It wasn't available to long-term care patients. And is it so now? They're going to be available, right, for them?
Yeah. Yes, it is available. It's not PA'd in our tribal ALTCS unit. It is PA'd through fee for service.
Okay.
Yeah, it is PA'd through that, and it is available, yes, to our ALTCS members. It's just not PA'd through our unit. But do you want to talk about that a little bit more, Vanessa?
I can chime in real quick if
Okay.
Vanessa's having problems.
Okay.
So as for the meals and lodging, typically the facility coordinator. The facility is the one who actually, they'll have either a care coordinator or someone at the facility will be able to make contact, the transplant facility. They will make contact with Access and say that this member has, just received a transplant and this is the need of that member. So usually somebody from the facility will let us know. It doesn't happen all the time. And I think with that particular case, it didn't happen, unfortunately, but it sounded like the case manager was aware that the member was going to go in for transplant. So the benefit is there for them. It's just, if we don't know about it because we don't process transplants for tribal ALTCS, it's hard for us to know if member needs any other assistance. We can always refer whoever the coordinator is at the facility level over to the meals and lodging team, and they'll go ahead and do that coordination. But if we don't know, unfortunately, like Sonny said, there was a member who paid over $1,000 just for lodging, just so that and meals, I believe, also. So, when the benefit is available, we want to make sure that we're assisting the member to ensure that they take advantage of that. We just don't want anything to be like this, be a hardship on anyone.
Yes,
Okay.
thank you, Rachel. Casey,
Um,
did that answer your question?
Yeah, I did.
Okay.
So it's just for transplant, and because we usually frequently get calls just for other medical appointments, not just transplant. And so,
Sure. If you
and
ever have,
kind of stepping back to the respite, the way it was presented here is that it can't be used in addition to attended care.
that's
But
correct.
how some families utilize it and how some home cares present it and kind of coach members is, for example, if somebody's getting 4 hours a day, let's say from 8 to 12, and they're going on an outing or something, or however they present it, and they want services and like at night or in the evening or something, and there's something going on medically with them. That to me, kind of looking at that is the way it's presented is that's in addition to attended care. But on the other hand, if you technically look at it, it's not, because it's attended care stopped during the day and then respite starting at night. So it's not continuous or not in addition to it. So that type of stuff really needs to be clarified.
Okay, so the issue is if it was going to be on a week, it was just 1 week, then that's one thing, that they need. But if it's additional care that member needs, then that's not respite care. That would be attendant care services that they need additional services.
Sonny, you're not understanding my question. I'm just using the 1 day example, not the way you're responding.
Oh, okay. Yeah. If it's 1 day, that's true. That absolutely, that would be correct. If it's just 1 day that they need respite care, yes, absolutely. That would be in if the member normally gets 8 hours, but the primary caregiver cannot do 8 hours for some whatever reason, then that could be utilized that way for respite care. But you would be reducing the attendant care and
Okay,
then
that's
having
kind of
respite.
confusing because, like, the way I'm saying is that in 1 day, the way it's presented is that the respite can't be used in addition. But on the other hand, technically, the attendant care stopped and then respite is being used. So it's not, so it's kind of that I guess the wording needs to get a little bit more clarification.
Okay, Rachel's going to elaborate on that. Okay, just a
Okay.
sec.
We can go back and look at the slide, Casey, and we can update it to make it a little bit more. If there's more people here that really don't understand what we're talking about when it comes to respite, we can go back and revise it. But if pretty much, if I guess I need to maybe, if people can go ahead and put a comment that you need us to revise the respite slides, go ahead and put your comment in. But if it's just certain, if it's not that very many people, most of you understand it. What we can do is we can set up a meeting with you, Casey, related to the slides, because most of the information that she put on there is from the policy. But I do want to just elaborate just really quickly, because I know we have other presenters. But if your case manager is assessing a member and we don't say when attendant care stops. We should never be thinking that. It's not just during the daytime. Members can need attendant care services at night. Maybe they need to be turned. I don't know. Maybe they need to build a fire at night, so that's it. You have to look at the overall H&T. What services does the member need 24 hours a day when you're looking at the H&T? And is there time in between, if it's documented on the H&T, that the member is wandering at night? We'll see supervision on there. Maybe they have dementia. We know that they may be getting up at night and they're afraid they're going to walk out. So the caregiver, that's the primary caregiver, is getting up. They have to go to work, but they can't get any sleep because they're constantly, every night, this is happening every night for months in and months out. That should be part of the H&T. And that should be to let them know, hey, they're going to need services during that period because, this caregiver can't do it. They have a full-time job. So in that instance, it should be part of the H&T. And, but if the caregiver says, you know what, this happens, but I'm okay, I'll provide the informal support. I'll provide it. I know that this happens every day, starting at 3 o'clock in the morning. I end up getting up, but I'm okay. I'll provide that service from 3 to 8 o'clock until the caregiver comes in. And then I'll provide informal support there. And then but then maybe 3 months down the road and says, I can't get no sleep. I need some rest, or I need to take a vacation. I want to go somewhere with my kids. At that time, that's when the respite can be in place. So we just want to make sure that that's that understanding there. So look at the member, look at the H&T, what service does that member need, and who can fill in. If it's the informal support that's providing, that lives there and that's been living with the member, they need a break. Yes, they can fill in that time that for rest, if it's informal support, and if not, then they want to take a vacation or whatever, they can fill in that gap. That's when respite will be put in place. Oh yeah, like Cheryl said, a second caregiver can be put in place if it's going to be more than the required hours. But just always pay attention to the CES, and if it's going to be more, if it's going to go over exceeding 80%, just educate the family members. We do that at our level too. We educate them on the importance of asking for more hours. And that's one of the particular case that we're mentioning this about is it was brought up to us by the provider, and I did have to educate the provider to let them know, you can't be doing this on a monthly basis. What are you doing? And EVV is now monitoring those services also. So they have to provide medical documentation. It doesn't have to be medical documentation. It could be their daily notes of what did you provide for respite. Now, if it's regular attendant care, if it can be counted as attendant care services, then it should be part of the S5125. But if it sounds a little bit too confusing, please let me know, Casey. Casey, we can always meet with you on this one.
Okay.
Okay, next And that's the end of my presentation. I'm going to turn it over. We're kind of running probably a little bit behind. So go ahead and go next. And I think it's Cheryl. Thank you.
Thank you, Sonny. Good morning, everybody. I will be doing PT and OT requests and also focusing on general supervision. Only page 1 and 4 of the HNT. Next slide. Okay, so occupational physical speech therapies. The main thing that I want you guys to know is that a PA is not required for any of these therapies, whether they be inpatient or outpatient. So you don't need to send a packet to our PA unit. It is the responsibility of the assigned case manager, once they receive the specific codes that a clinician that has evaluated the member or needs to evaluate a member for any of these therapies. The evaluation will always be only one code, and it's usually through the 997 codes that you'll get, the HCPC codes. There'd be one unit for that, the evaluation. And then any other, after they get the evaluation, they'll start out with the other codes that they'll be needing, like exercise, strengthening, weight bearing, things like that, depending on what the member's condition was. So the clinician will fax you the list that they are asking prior authorization for. We are sometimes getting these through our portal, and it's going to the PA unit, and then it bounces back to tribal ALTCS because the tribal case manager is able to put these codes in at your discretion upon receiving that request for the frequency of these specific exercises that they want the member to go through, and you can enter those. So in that case, they will usually give you a date span of maybe a month or two. So you go ahead and put it in as they send it to you. Sometimes they may call you back or contact you back and say, hey, I need an increase on muscle strengthening because the member is doing good, they're making progress. So then they may ask for additional units, and you can enter these. So the codes for the occupational physical therapy codes, they're allowed 15 units per calendar year. 15 units per calendar year. So you're starting October 1st, 2022 to September 30th, 2023. That's the calendar year for these services. Next slide. The case manager, again, does not authorize these services, and they get 15 visits per calendar year. The PT and OT services are going to have to be received through a licensed Medicare certified, either a home health agency or a licensed physical therapist, occupational therapist, or speech therapist in an independent practice. One thing I want to let you guys know that sometimes you will get these referrals and they will have a provider ID. It's your job to look at the provider ID and check on your RP005, make sure an access provider, and then you can enter. So you go in entering the codes, and then you get an error that the provider is not allowed, because like a PT/OT therapies company, sometimes they're under a provider type 01, which is group payment. That means that under A, B, and C's physical therapy, they have a number of clinicians in their company that they have separate PT, they have OT, and speech therapists. What you'll need to do is then go back and say, I cannot enter this because the ID you gave me is under a group payment provider type. So you need to see which clinician is actually going to be doing the therapies for the member. You get the name of that person and you look up the person under the PR005 the same way. Each clinician will usually have their own provider ID and their own MPI. Then you can try looking at that and entering that into the system and see if it will accept it. Then you let the provider know it went in under this specific Minnie Mouse PT physical therapist, and so I'm going to put it in as such. Now, the other thing that happens is if it's a group provider ID type, then sometimes that ID will be under a corporate provider profile. So that specific clinic or that specific occupational PT or OT, it's going to go to their corporate office. They're not going to see that PA letter once you've put in that PA. So you also, again, as I stated before, education to the providers, to the members is very, very important. I sometimes look back at screens when I've given TA assistance to case managers that come across the types of example I'm giving now. I look back maybe a month or two later, and I still see that those PAs that the provider had requested have still not been billed yet. So I may make contact with the case manager and say, hey, did you look at your screen? You should be looking at your screens, monitoring your screens. That's an important case manager standard. How come this PT hasn't happened for this member? Can you check on it? So that's where I see some of this coming up, and I thought I would touch on this. So next screen, please. And the links are there to really look at the policy on it. Again, I'll say OT, PT, speech therapy. These therapies do not need a prior authorization from our PA unit. Thank you. Okay, now next is the general supervision. Ever since we started doing our weekly CES reports and getting the list of all our members who are greater than 80% CES, then I'm noticing this, is that there needs to be more meetings in your programs regarding general supervision. General supervision is only going to relate to how you answer on page 1 and 4. It's going to have to do with the assessment of the living situation. If the member lives alone or if the member lives with in a multi-generational home. And a lot of our members do live in a setting such as that. The second aspect of this is the supervision need. Now, is it because the member has dementia, is wandering, is confused, or is the member just totally unable to call for help if they need it, or they don't have a lifeline? So we went over that at one time about lifeline. We asked different tribes. I sent out an email to ask how their emergency response or how they handle, a situation of life about needing a lifeline. A lot of our tribes, most of them said that within their tribe and their utility company, communications company, it was paid for by their tribe for every member of their tribe to have it. So that is really awesome. That is really something that we talk about would go through tribal sovereignty, because you're ensuring that a member is safe and that they are able to, without having to pay out of their own pocket, the tribe is helping them be able that their phones, their landlines or their phones are set up to call 911 if they need it. And then if you check NA on this, on the supervision need, then you should not have any time assessed, paid time assessed for the supervision need. Next slide. So the wandering risk is a member has already been found and is you've been told that they leave their home unsafely or they are unable to walk back. The key one is dementia for our members with dementia. That's a high risk. They would need general supervision. Confusion, disorientated, and a risk to themselves. almost the same as wandering, because if they wander out, they're going to be unsafe outside, especially if it's 100 degrees, 106 degrees here on the res, or 118 down in the valley area. So that is a huge risk also during the winter months up here, up north. Or if they go to the stove and want to cook for themselves and they leave the stove on, they forget to turn it off. Those are definitely high risks for injury, and that would be general supervision could be allotted there. Next slide. And the other one is unable to call for help even with the lifeline. So this one is a person, I saw a really good example. One was a person was totally blind, immobile in bed, but couldn't really move around to get up and call a lifeline. They had their cell phone set up when the caregiver left the house. But what if they couldn't get up and call, or they dropped their phone and they couldn't reach it to call? So we can't have 30 minutes for general supervision. That's excessive, because what it's saying here is if the member is found by somebody, or the caregiver comes back and says, hey, I just don't have a good feeling, let me go back and check. So they go back and check and they find that the member is in distress. Okay, even with a landline, it is not going to take 30 minutes to call for help. You're not going to assess 30 minutes each night for general supervision. The call for help is going to be like 911. And then I know a lot of you are going to say, well, it takes more than 30 minutes for the ambulance on the res to come. Still, you're going to be there just to, what they're talking about is just getting that call out for help. The rest is, you're covered under a Good Samaritan law to stay till somebody comes that can help. So there's a lot of different case scenarios here, and you just have to really critically think and think outside the box on each of these. I'm seeing a lot of general supervision that are being used excessively. Then also, if the member lives alone, again, kind of encompasses everything I already did mention. There's some case manager documentation that is really good and actually paints me a picture of how the caregiver leaving the home assess and ensures that the member is okay, and they let the family members living next door that I'm leaving now, and the family members then by informal support know that, okay, the paid caregiver's gone, so it's up to us to go and check before we go to bed and then first thing in the morning, things like that. So general supervision cannot be used if the time is already calculated and assessed in all the activities of daily living. If you say the member is weak and cannot get into the bathroom at night, you can't use it for general supervision. You have to put that time in with transferring and moving around. Now, if the person has to get up and go and a family member gets up with them, that too cannot be 30 minutes. It's only going to be 5 to 10 minutes to help them in and out. So you're going to have to really assess it carefully. Next slide. And this is the page 4 that I was talking about. It's based on a need and can be provided based on the member's need identified on page 1. Remember that supervision is built into everyday ADL. So general supervision specifically relates to the member's needs identified on page 1. It can't just be for routine ADLs. Next slide. Thank you. Is there any questions? Thank you, everybody.
Good morning, everyone. I'll be going over Open Night request form today. Next slide, please. Oh, Rachel, you have questions?
No, I wanted to just play the devil's advocate here to Cheryl. Say if a person, if it was noted in the H&T that the member gets confused and not all the time, but does, get confused at times, and they tend to walk out of the house or maybe try to cook something early in the morning. In that instance, but it's happening so often. That will be, you did mention on the H&T, they would put the confusion there, right? And they're also wandering based on what the questions were asked. And the case manager would then say, oh, what time are they wandering? Oh, they usually get up at 3 in the morning. So that will be part of the H&T assessment, correct?
Correct.
Okay.
And
Thank you.
also, you're welcome. There's also different types of interventions that families can use. If, again, the main goal is to have the members stay in the least restrictive environment. So there's different types of things that families or caregivers may need if the member's still in the home with families, because there's like bed alarms, there's door alarms. So it's like an alarm is put underneath the mattress or on the mattress. Once the member stands up, there's a little alarm that goes off, and that alerts the family member, whether it be in the other room, to wake up and say what's going on. So again, we're not going to do 30 minutes a night for that, but things like that are interventions that can help members, continue to be safe in their own home. If it gets to the point where it's constantly every day happening, nothing has worked, medication is not helping, then again, there's that option of the last resort, which Sonny mentioned before, is a conversation to be initiated regarding skill care, memory care. Sometimes it gets to that point, but again, there's some interventions that can be requested, like the alarms, things like that. Thank you.
Okay, go ahead, Bandana.
Okay, thank you. We are seeing some issues and we want to make sure everyone is on the same page. Case managers should be utilizing the fillable open write request form located on the Access Travel ALTCS digital toolbox. However, if you need to handwrite them, please ensure it's legible. I have attached the open line request form link. Next slide. Case managers should use the drop-down box to select your program or the office. Tab Next and fill in the case manager's name, member's access ID number, and member's name. We have noticed that some open line requests have really small fonts and difficult to read, so we have modified the form and it is uploaded to the digital toolbox. If handwritten open line request forms are not legible, then we will deny the open line request and it will need to be resubmitted. Next slide, please. On the open line request form, please put exactly how the correction should appear in the space in the table section. We need to know what changes needs to be made. For example, was informal support provided or member was hospitalized? Next slide, please. Please provide an explanation as to why the line needs to be open. Please make sure the case manager and the supervisor's signatures are on the form, including the date. Next slide. Please provide a screen print of the CA-165 and what the line looks like before the corrections are made. Next slide, please. Thank you. Any questions?
I have something that we probably need to revise on slide 37, where we don't deny any requests. If it's something's going to be denied, we have to provide an NOA. So what we do is we reject the requests and provide a response to the program, so that and let you know why we're rejecting this request, and you would need to resubmit it. So we're not denying it because we just need clarification from you all. So we'll go ahead and update that slide. Thank you.
Okay, right now we're going to go ahead and take a 10-minute break. So we'll be back at 10:38. Thank you.
Thank
Thank
you,
you, everyone.
Mandana, for getting us back on track.
Yes.
Welcome back, everyone. Can we go on to the next slide?
Yes. Here we go.
Hi, it's nice to see everyone, even though it's virtually. I'm Maria Dorado, the Tribal ALTCS nurse. Next slide, please. So what is prior authorization? Prior auth, otherwise also known as PA, is a process by which the Access Division of Fee for Service Management determines in advance whether a service that requires prior approval will be covered based on initial information received. PA may be granted provisionally pending on receipt of required documentation to substantiate compliance with the access criteria. Just a reminder, PA is not a guarantee of payment. Next slide, please. I've also provided a slide here of PA requirements. The following guidelines will help providers determine when PA is required. We also have a link available in the bottom. Just a reminder, PA is not required for FFS members receiving services from Indian Health Services, emergency services, FESP members. Next slide, please. This is just a little visual of the DME PA process. The DME request is received via fax. Then it is reviewed by my specialist, Charlie, for the DME required documentation. If the PA packet is incomplete, it'll be returned. The entire packet will need to be resubmitted. The next is complete DME requests will be reviewed by the clinical nurse, which is myself. Approvals pending PAs will be entered into PMMIS, and then an email will be sent to Charlie. Myself or Charlie will then send the DME letter to the assigned case management health plan via secured email. Coming soon, and the DME will be in a DME fillable form and digital toolbox is this durable medical equipment authorization request, and it's just like a cheat sheet of what will be needed to be included in the packet. And that will be coming soon. Next slide, please. We also will be coming soon having a specialty rate request check sheet. Authorization of specialty rate may be extended from 90 days to 180 days or less if request is an initial request dependent on clinical review. That's something good news. So instead of the 90 days, it could go up to the 6 months. But if it is initial request, it could be less. You will receive a date for your next scheduled review. This can be sooner if the status changes. Next slide, please. It is great news, Cheryl. I just need to remind you guys to please fill out the PA required fields. Not doing so will result in misfiling a PA request, and it does delay. It could get lost in our system. and it needs to go to the correct department. So what's going on lately is that even for the ALFs, they're check marking the NF review special box instead of the assisted living facility BH. Can you guys see that? And that happens a lot. So please ensure that it's correctly filled. Next slide, please. For receipts and imaging department, the faxes that do come in, just a reminder that there is a 72-hour turnaround. Please take that into account when sending in a fax or contacting the health plan to check status on a fax. Next slide, please. Again, use your current PA form. Our current governor is Katie Hobbs, with the Carmen Heredia is a director. We're still getting a lot of forms that are no longer valid. Just a reminder again, use the correct type of documentation, the BH, sorry, and above all, your access ID for the provider. It does delay when we have to look at who the provider is, and there may be mistakes. A lot of the facilities have the same names. So please, I ask you, please put on your access ID there for the provider. Next slide, please. Faxes will be returned if you're not using the correct form. A letter will be sent to you as to why. Next slide, please. We've also provided here a fillable PA request form links, so you could use in the future if you need to use a PA request form, a PA correction form, a PA medical documentation form. Next slide, please. Orthotics and prosthetic devices. Just know that orthotics are used to support, correct, enhance the used part of the body, and prosthetics is an artificial limb that replaces a limb on a person's body. For members, when medically necessary, as specified below, for over ages of 21, as specified in AMPM policy 430. For members age 21 and older, the following apply. The use of the orthotic is medically necessary as the preferred treatment option consistent with Medicare guidelines. The orthotic is less expensive. So whenever a pay packet comes in, these need to be attached as well. Some supporting documentation that it is less expensive and that it is medically necessary. For orthotics age 21 older, the statements need to be below. Is the use of orthotic is medically necessary and it is less expensive. Just a reminder, for diabetic shoes, member requires a letter certifying that the member has DM and supporting diagnosis. Next slide, please. This is just an example of the prescription form and orthotic is less expensive statement. This normally comes from one of the providers, and it's a guideline here. And they need to check the most appropriate box below. Often the box below is not checked at all. Next slide, please. And it's just updated access PA claims process for customized wheelchairs. Next slide, please. Customized wheelchair process. If the DME is covered by a Medicare third party, Medicare PA is required, yes, pending PA. Access responsibility, deductible coinsurance. If the DME is not covered by Medicare third party, valid denial required for SNF members. Yes, it's pending in PA. Just a reminder that the access responsibility is if a member is going to require past the 13 months purchase is recommended. Temporarily, less than 6 months, a rental is an option. If the modifier is being changed from NU to RR, a med review for denial will be needed to be sent to the medical director, pending PA with PH001. If Medicaid is primary, the rental is a first option, but clinical review can determine purchase. If modifier is being changed from NU to RR, a medical review for denial will need to be sent to the medical director, pending PA PH001. Next slide, please. This is an example of an EOB Medicare denial letter. So if Medicare is primary and we're requesting an EOB letter, this is an example of the type of letter that we need to get. A lot of times I get a PA detail letter. That is not a Medicare denial letter. Next slide, please. This is an example of a delivery ticket in cases of where the provider, DME provider, has sent the item to the member first, and they need to supply a delivery ticket within the packet. Next slide, please. This is an example of a PA pending letter. For example, if the member is Medicare primary, we will still put it in the system as pended and then send a letter to the case manager informing them to inform the provider that it is in the system as pended, but Medicare is primary and we do need a receipt of the Medicare EOB reflecting of the denial. Next slide, please. For quotes, please ensure that each item, please note that each billing item is individually priced. Once in a while, we do get a bulk code of price, and this code will be sent back for individual billing prices for unlisted codes, and it does delay getting authorization for the member. Next slide, please. DME H Healthcare Partners is a trusted partner providing. Go ahead, Vanessa.
I just wanted to add here, the custom wheelchair process, we have met with providers and we have gone over our processes, so they are aware. We did ask for brochures from providers that are willing to do custom chairs for our members. DME Healthcare Partners is one of the providers that do custom wheelchairs. The next slide, Charlie, is Rider Mobility. They've also shared their contact information, where and what parts of the state that they service, and how you can contact them. We have also met with Preferred. Once I get their information, I can send it over to the case management offices so that you guys can also utilize them. This will just give us more opportunities as far as other providers who would be able to render services to our members. Next slide.
Okay. Claim questions. For claim questions that cannot be resolved on the portal, please outreach to claims customer service team and in the phone numbers provided. Select option 4. And this is from Monday to Friday, 7:30 in the morning to 4 p.m. Phoenix time. For provider training resources, technical assistance regarding claim issues and training, please email providertraining@azahcccs.gov. Next slide, please. AM/PM chapter 1200, and this is in regards to the off-page requests. Next slide, please. Please ensure that the documentation that is submitted with the packets is legible. A lot of times we get it very blurry. Sometimes there's no name on top of who these notes belong to, and there's no dates. Ensure that there is dates, please, and names. Next slide, please. For acute care services for tribal ALTCS members, acute PA requests for tribal ALTCS members must be faxed in to DFSM, and the number is provided. If a provider gets directed to you, educate the providers to submit requests for acute services to DFSM. If the provider states they are being informed to contact case manager by DFSM, please request the name of who they are getting the misinformation from. Next slide, please. We do have an acute service request process. Go ahead, Vanessa.
We had a request just to go over the acute care service request process. For the acute care services, if you do receive any requests pertaining to acute care hospital stays, laboratory, clinic, dental, MD, etc., I did outline it in the first bubble as far as what acute care prior auth. if you get any of these requests, please direct the provider to fax to DFSM, and their fax number is in the second bubble. This request can be faxed directly from the provider. The tribal case managers do not authorize these requests. Once DFSM receives the request, they will process it and enter it into their PMIS screen. The providers will get the response from the provider web portal or via fax. The providers will need to log into their web portal to get their PA determination. The tribal case managers will not receive any notification from DFSM. So it is the provider's responsibilities to check their web portals or check their fax machines to see if they've received a response regarding their prior auth. In the event that the case manager does get this request and the provider is pretty adamant about the case managers authorizing these, if you can give us a call or send us an email just with the provider's information so that we can contact them and provide some education. Thank you.
Next slide, please. Just a reminder, the new fiscal rates will be starting at October 1st, 2023. Anything
That's a
else you
good
wanted to add,
point.
Vanessa?
That's a really good point because we all have to remember those come out.
All right, next slide, please. I'm sorry, Vanessa. Did you want to say something?
Oh, no, I was going to talk about the second slide. So we are receiving requests for the new rate period. Just note you will get a pended letter just stating that it's been entered and we're waiting for the pended rate. Please don't send any duplicates. We are tracking these. So once we get the rates, we'll be able to send out the approval letters in the order that they came. So just so you're aware. Thanks, everybody.
So are we noting,
Rachel?
so are we noting anything in CA 165 just to let the case manager know in the event that they're, they're having issues with their fax machine or response back? Are we putting notes in CA 165 just to let them know that it's pending, just in case they look there in the comments?
Charlie would be putting the notes into the CA 165.
No, I have not, but I will start doing that.
All right, yeah, just so in the event that maybe their phone lines are down, a fax machine is down, that way they can see it in the system. Thank you.
Will do. Thank you.
Next slide, please. Just a reminder that anyone can report fraud, abuse, or member abuse. There are no restrictions and you may remain anonymous. OIG depends on employees, members, providers, and the general public to report any suspicious fraud or abuse. We have numbers here, a report member, provider, contractor, suspected fraud or abuse of the program online forms. We have, if you report suspected by fraud by access member, there's a number below in Arizona and a toll-free number of Arizona only. Contact the access officer or inspector general with questions about fraud, waste, or abuse of the program or abuse of a member at accessfraud@azahccs.gov. Next slide, please. Thank you. Any questions?
Amazing. Everybody did a great job. Are we ready for our guest speaker?
Yes, we are. So
Yeah, sorry, that I was going to say the guest speaker is here.
Awesome.
go ahead. So we have Dr. Ramon Velasquez here joining us today. He is an assistant professor from ASU School of Life Sciences, and he runs his research program at ASU Disease Research and Center. He has received his PhD in neuroscience from Cornell University in 2014 with a strong focus on brain disorders. In addition to performing research tied to brain health and prevention of diseases like Alzheimer's disease, he also teaches upper division undergrad courses at ASU, and particularly physiology with 366 students in the graduate level course on neurodegenerative disorders. So today he will discuss the progression of Alzheimer's disease, other dementias, and methods to promote a healthy brain. Welcome.
Thank you so much. I'm going to go ahead and attempt to share my slides. Let me see. I usually don't use this platform, so bear with me a little bit. If I can get some guidance on how I actually share my slides, that'd be great.
Sure. Down at the bottom, you see the 3 dots.
Uh-huh.
You're going to go ahead and click on the 3 dots, and it should give you, let me go ahead and stop sharing mine.
Okay.
Or no, it's not the 3 dots. It's actually the screen with the arrow in it.
Okay.
Okay, you're going to go ahead and click on that, and then it'll show you which the screen that you want to show.
Gotcha. I think this is it. Allow. Is that being shared?
Yes.
Now, do you see it with notes, or do you see it with no notes?
No notes.
Okay, perfect, great. Then that looks like it's good to go then. Okay, so I'd like to first start off by thanking the organization committee here. I've been talking specifically with Charlotte Little, who invited me to give this seminar today on a very important area of research that really affects our society today drastically, and that is in the realm of Alzheimer's disease and other forms of dementia. And I really want to start off this presentation by describing what are the differences, right? We all hear about Alzheimer's disease, and it's the most common known cause leading to dementia. However, there's very different types of dementias, right? Some examples are Parkinson's disease, Lewy body dementia. What really differentiates that, and what classifies them? So we'll talk a little bit about that. And then we'll also talk a little bit more about some of the preventive measures we can take to try to offset these diseases, right? We know from our research that 95% of those individuals that are affected by these disorders is really a result of environmental factors and some aspects of lifestyle factors that we can address. The other 5% are due to things like genetic mutations in their genome. And while these specific brain-related exercises we can do to try to promote brain health help those that get the disorder, that might get the disorder, or prevent the disorder from those individuals that get it just based through the environmental factors. It can also help those that have genetic mutations. So before I move on, I just want to highlight and say that any questions, please feel free to stop me. More than happy to answer anything related to clarification, or if you just have a question that you just want to raise. Also, just want to highlight this little QR code here for those of you that are interested in learning more about our research here at ASU and in my lab. This will take you directly to my website, and you can see the work that we have currently ongoing that's funded by the National Institute of Health, as well as by the state of Arizona. Specifically, there is an Alzheimer's consortium here in Arizona. So I want to start off and just giving a little description about me and my work and what we do here at ASU, and what we really are looking at in terms of ways in which we can reduce the incidence of disorders like Alzheimer's disease. So we're really interested in determining the early events, and specifically the lifestyle factors that can promote healthy brain function and deter from disorders like Alzheimer's disease, right? So one of the areas that I'm really focused on and interested in it is looking at how diet can affect the progression of disease and slowing the progression of the disease, or even the incidence of it, as well as how environmental toxins can lead potentially to the disorders. There's actually interesting data showing that individuals that live in states where there's more pollution have a higher incidence of developing disorders like Alzheimer's disease. And we're actually doing some research that looks at how certain pesticides that are found in various foods can actually exacerbate the disease. We also have a few initiatives to look at drug therapies, right? So we have developed a few drugs that are in the pipeline that'll make it to clinical trials, and hopefully one day we'll make it to the patients. And we're currently working on those to slow the progression of the disease and also help those individuals that are really more in advanced stages of disease. Here you can see what's called the Biodesign Institute. That's where my laboratory is located, and we do our research at the ASU Tempe campus. So I kind of just want to start off by building the foundation of, what does the brain do, and why is it so important, and why do we really need to do a good job about, in terms of taking care of it, right, to try to deter from these disorders, right? So the brain really allows us to have everyday functions that a lot of us really take for granted: speech, hearing, being able to see this presentation, being able to remember the presentation after the hour is done. All of that is really relying on the brain, which is critically important. And it's made up of these cells, a variety of different cells, but really the important cells are known as neurons. And everyone here has billions of neurons that make up their brain and allow us to really navigate through our environments and produce these specific behaviors. Now, one thing that's very interesting to note about neurons is once they're damaged and they die, they can't be reproduced. So you can imagine in disorders like Alzheimer's disease, if there's certain neurons that are dying, they're gone, that behavior is then affected, right? So I think that's a good way to think about how we need to find ways in which we can protect these specific types of cells so our behaviors don't become compromised later on in life, right? And these neurons are also more vulnerable with the aging process. As we age, there's a lot of things that happen based on our environment that can compromise these neurons and ultimately their function. And so you can imagine here, you can see an actual brain of an individual, what it looks like. This is a side view. And when you put these neurons together, they create what's called brain regions. These brain regions, as you can see here, are all tied to specific sorts of behaviors, right? So the frontal part of your brain is associated with reasoning, memory. The more caudal or back, you have areas associated with movement, sensation, hearing. These are all once again made up of those neurons, right? And they're formed in this way in the brain because there's so many neurons, there's billions of neurons. That's why you have these small little creases, because if you didn't have this specific folding, our heads and essentially our brains would be humongous, right? Because they would not, they would occupy much more space. So that's why we have what are called cell societies, essentially these foldings in our brain, and that's why you see them. But really the take home here is that these cells, known as neurons, produce behaviors, and we got to do whatever we can to protect them, because once they die, it's very difficult, nearly impossible to get them back, okay? So as I mentioned, I want to kind of jump off and talk a little bit about dementias, right? So when you hear Alzheimer's, everyone always thinks, oh, Alzheimer's means dementia. But what is dementia, right? So dementia's general term is it's memory loss and other deficits in mental abilities that are severe enough to affect the individual's daily life, right? So these individuals need caregivers. These individuals need someone that helps them navigate through their life and their environment, because those neurons, those cells of the brain, are now affected so severely that they can't do simple tasks. Things like remember, oh, where did I leave my phone or my keys, or did I have lunch today? Things of that sort, right? And that's what we mean by dementia. Alzheimer's is one route to dementia, but there's other different disorders that can lead to dementia, right? And once again, it's caused by these changes that occur to the brain and ultimately the neurons. So what are some examples of other forms of dementia? Well, there's vascular dementia, right? Vascular dementia is a result of your vasculature being compromised to the point where it can't deliver proper blood to your brain. And blood is important to reach your brain because it carries oxygen and nutrients. So if that vasculature is compromised, either because it's clogged or either because it's leaky, that can lead to deterioration of those specific neurons, once again, that ultimately then affects your behavior. Another disorder, this is a disorder that Bruce Willis was recently diagnosed with. This is frontotemporal dementia. This is a disorder that affects the frontal part of your brain, and it typically is associated early on with deficits tied to decision-making and moral judgment, right? And personality changes are really seen in these individuals that have frontotemporal dementia. But as a pathology, we'll talk about that in the next slide, affects other brain regions, it'll then start to affect other specific types of behaviors. And then a very common one is Parkinson's disease, right? So Parkinson's disease is more classified as a movement disorder. Individuals typically have tremors, have a very hard time controlling their movement, severe enough to affect, for example, walking and various other aspects of movement. And that's a result of specific neurons that control movement dying, right? And ultimately, if the individual that has Parkinson's disease lives long enough, typically about 20 years, they then develop dementia because the pathology goes to other areas of the brain that affect specific behaviors, okay? And if there's any questions, feel free to interrupt me. I can't see the chat, but if there's a chat and someone can let me know if there's questions, that'll be great. Thank you. So what defines these disorders, right? Why is it that we have Alzheimer's disease and Parkinson's disease and Lewy body dementia? Well, really the reason why they're defined this way is because there's certain pathologies, that is proteins that don't belong in the brain. And what happens is they accumulate in the brain and then they compromise the function of those neurons. So remember, once again, those neurons are important in producing behavior. Imagine that these proteins that don't belong near neurons begin to develop in such a way that they compromise the function of those neurons. Ultimately, those behaviors are compromised, right? And really, there's hallmark pathologies in all these different disorders that distinguishes them, right? So in Alzheimer's disease, you have, for example, what's called a tau tangle and an amyloid beta plaque. You can think about these as sticky plaques outside and inside the neuron that begin to compromise its function so the neuron can work properly. And ultimately what happens is that the individual's behaviors are altered because the production of those behaviors are altered because the neurons aren't functioning properly. Another example is Lewy body dementia. So you can see here, for example, this is a cell, let's say it's a neuron. There's these accumulations that occur inside the cells, and essentially they then disrupt the ability of the cell to work properly. And what that leads to is the inability of that individual to produce that behavior because the neuron is compromised. And in frontotemporal dementia, you have another protein. It's called TDP43. It develops and it leaves the cell. It's not supposed to leave the cell, and by doing that, it then alters the function of those specific neurons. So ultimately, the diseases that we characterize, these different disorders, are characterized by specific proteins that develop that shouldn't be there, and those are called proteinopathies. And also where they develop is what classifies this disorder, right? So in Alzheimer's disease, it's typically tied to specific functions or brain regions that produce learning and memory, right? That's why memory is one of the first complaints of individuals that have Alzheimer's disease. With Parkinson's disease, it's areas that are tied to motor function, and with frontotemporal dementia, it's areas that are tied to the frontal cortex that produce behaviors tied to decision-making and moral judgment. So let's dive in and talk a little bit about Alzheimer's disease and why we're so invested here in the United States and really the world in finding ways in which we can slow the progression and halt this disease, because it's so prevalent. In 2023, the Alzheimer's Association published these facts and figures, and just for everyone who's here, so in the future, if you'd like to get an update, the Alzheimer's Association actually publishes facts and figures every year, so you'll get an update of these statistics tied to Alzheimer's disease every single year if you look them up in their website. Currently, there's 6 million Americans that are affected by this disorder. It's a very, very, very high number. Worldwide, 47 million people are affected with Alzheimer's disease, which is a very, very high number. The reason why we're so invested in slowing the progression of this disorder by looking at treatments and preventive strategies is because if we do nothing now, by the year 2050, worldwide, we're looking at 153 million people affected by this disorder, which is a very, very scary number. And that number in the United States alone could be upwards of 14 million Americans. So really, really a high number. Some interesting aspects about Alzheimer's disease that we're starting to learn more about is that it affects women more than men, right? And question that scientists have tried to ask is, why is that, right? Why are women more affected than men? There is some evidence suggesting that these shifts in estrogen during premenopause and postmenopause can play a role. Also, stress response. There's some statistics showing that the way that women deal with stress can actually is different than men and can actually exacerbate these changes in the brain. One of the things that's very well known in the literature is that stress is bad. So if anyone has stress, you got to find ways to mitigate it, because not only does it affect your brain, it can really affect overall your body and your metabolic function. For example, it can lead to things like diabetes and hypertension, which we'll see in the next couple of slides are actually precursors to Alzheimer's disease. So what are some of the clinical symptomologies that you see in this disorder? Memory loss that disrupts daily life is probably the most common feature that you see in Alzheimer's disease early on. And I'll give everyone some examples, because this is one of the things that gets a little, it's an unclear, right? What's really a memory deficits that can suggest that there might be some sort of Alzheimer's disease early symptomologies brewing. So if you're, for example, unable to remember, I don't know, a calculation you learned 30, 40 years ago, that typically doesn't really is not tied to Alzheimer's disease, the early effects or the early symptomology. It's really tied to, for example, if I was to ask everyone in this lecture today, can you tell me what you did yesterday at 11 o'clock? And if you were unable to say, oh, I attended a lecture, I remember there was a faculty member that was giving a lecture, that sort of memory is the one that's typically tied to the early changes that we see in Alzheimer's disease. So it's being able to create new memories, not forgetting those memories that are already established in your long-term memories, right? So that's a key distinction. As a disease progresses, there's changes that occur. For example, confusion with time or place, changes in mood and personality, as well as challenges in problem solving typically are seen later on as the disease progresses. And that's really where caregivers come in and have to really help these individuals with the disorder, because it's very difficult for them to navigate their everyday life by themselves. So here we can see what the brain looks like with these proteins that don't belong there, right? As I mentioned, every disorder, the brain disorder, neurodegenerative disorder is tied to a specific pathology. In Alzheimer's disease, you can actually see here, this is a human brain section. You see these brown sticky plaques. Those are known as amyloid beta plaques. And then you can see these dark triangles. Those are actually neurons, but inside of them, there's this protein that accumulates that compromises their function. So you can essentially think about it as this gunk and trash is developing in the brain, and it's very difficult to get rid of it. And as it accumulates in the brain, essentially what you have is that those neurons that produce our behavior are being compromised, because they can't function properly, because all this excess trash is essentially compromising their function. If we look at a brain of a normal individual versus one with Alzheimer's disease, we can see that in post-mortemly, so that is after they pass away, they have shrinkage of areas of the cortex, areas tied to learning and memory, and their ventricles. These contain fluid in them that's important to wash away toxins and waste, actually increase in size because there's so much loss of tissue in the surrounding brain. So really the brain actually shrinks and actually atrophies in this disorder. Now, in terms of who's being affected, one thing we know about Alzheimer's disease is that it typically affects individuals that are older, right? We know that from the 2022 facts and figures, had 1.75 million that were affected by the disorder are between 65 and 74. However, the majority are over the age of 75 to 84, right? And one thing that's critically important here is that just because the disease is diagnosed at these ages does not mean that that's where the disease begins. There's a lot of research suggesting that 30, 40 years before these ages, and you actually have clinical symptomologies, things are already occurring in the brain that might be leading to some of this clinical symptomology later on in life. So we have to find ways in which we can improve our brain health to deter from one actually getting Alzheimer's disease. And why are we seeing an increased prevalence rate of these disorders, specifically Alzheimer's disease? Well, if you look at the life expectancy since 1970 to 2021, it's increasing for every single country, right, in the world. You see that people are living longer. Since they're living longer, now you have more incidences of Alzheimer's disease that are occurring, right? So we've been able to make a lot of medical advances to be able to help people with cardiovascular issues, with things like metabolic disorders, for example, diabetes and hypertension. But it's been, but while we've been doing that, individuals are getting older and we're allowing them to live longer, but now more issues are coming up like Alzheimer's disease and dementias, and we have to find ways to offset that in order to reduce the incidence rate and that daunting number that I brought up, which is 14 million Americans being affected by 2050. So a lot of progress has been made in various diseases throughout the last 20 years. I mean, if we look at things like breast cancer, disorders like breast cancer, prostate cancer, heart disease, we've decreased the amount of deaths that occur from these disorders. HIV is one perfect example of a specific ailment that medical advances have been able to make really, really significant effects and reduce the amount of individuals that have passed away because of that. But what about Alzheimer's disease? We're seeing that it's actually going up, right? The number of deaths caused by this disorder is really strikingly large. So we need to find ways in which we can slow the progression of this disorder. One thing that is critically unique about this disorder, and I shared this in a lecture I gave about a month ago to another group, is the proportion of people that get Alzheimer's disease based on their ethnic background and their specific background, right? So what we find is that white Caucasians typically have lower incidences of developing Alzheimer's disease, and African Americans, actually, and Hispanics have a higher prevalence of developing that disorder. There's a higher percentage of Hispanic and African Americans that actually develop Alzheimer's disease compared to whites. Now, the question is why, right? And this is an area of research that's not only very it's interesting, but it's controversial, right? Because is it a result of some sort of genetic predisposition that African Americans and Hispanics have? Or is it issues related to socioeconomic status, access to healthcare, things of that sort? I'm Hispanic, and I know that, you know, for my parents being first generation Hispanics here in the United States, or myself being, they actually immigrated here. A lot of times they're very hesitant to go to the doctor. They really weren't aware a lot of the availability of healthcare, things of that sort. And you know, we also in my family, for example, diabetes is very prevalent, and in a lot of the Hispanic and African American populations as well. And we know that diabetes and hypertension are actually a precursor to Alzheimer's. So it's a very complicated scenario here, but this is what we're really seeing, that it does predominantly affect African American and Hispanics. And now, in terms of Native Americans, I did have this question last time about the incidence rate. It's actually lower in in Native Americans, but when you look at the data and you dissect it, it's actually because life expectancy is significantly lower in Native Americans. So it's not that there's less Native Americans that are getting the disease, it's that a lot of them are dying much younger, unfortunately, and that's why you don't see the incidence of Alzheimer's disease. If you go back and look at the facts and figures, you'll see that most individuals diagnosed with Alzheimer's disease are over the age of 85. From my understanding, the life expectancy of Native Americans is about 62 years. So they're not even reaching that specific point in age where typically Alzheimer's is seen. I think chats are coming in.
Yeah, we have a question from Cheryl and also from Yvonne.
Okay, so I see the question can wait till the end. So why don't we wait till the end? I just see one question. I don't see two.
There's
Yeah.
hands raised.
Yeah.
Oh, her hand raised? Okay, great.
Yeah.
Yvonne.
Yeah, this is Yvonne. I'm an epidemiologist and I have been studying certain aspect. They say that Down syndrome individuals do not get Alzheimer, and there's been study on it, and they want to do some tests on them and study more. Why do they not get Alzheimer? Also, anybody that is a midget, a dwarfism, or anybody shorter than 5 feet, maybe 4'10" or 4'9", I believe it was, that they don't get Alzheimer's so much purposely. And it's no matter what race, they could be Black, Hispanic, or Native American. If they're short, it's something about the I think it's the DNA or the genetic aspect of them that's probably one of the reasons why they don't get Alzheimer. Also, with these individuals, Down syndrome don't even get cancer, period.
Yeah.
And also the short people too do not get cancer as much as if you're average of 5 feet and taller. I thought that was quite interesting. The article I read about that, and also I've been some conferences working with Down syndrome individual. Thank you.
Yeah, so that's a great comment, and actually one thing I didn't share because of the brevity of time I have, but I actually study Down syndrome here in my lab, and we actually, you're absolutely right. So, and since you brought it up, I'd like to, I'd like to talk a little bit about it. So Down syndrome individuals, virtually all of them get Alzheimer's disease, right? The reason why we're saying that they're all getting Alzheimer's disease is because they're living longer. It goes back to the point about all these medical advances we've made. The last 30, 40 years, the life expectancy of Down syndrome has gone from about 20 to 30 years to about 50 to 60 years, right? So they're living longer, and we're saying that they're getting Alzheimer's disease, virtually all of them. Why is that? So in Down syndrome, there's a triplication of a chromosome, right? So we all have 2 chromosomes. We have 21 of them, and one of them, the 21, actually triplicates, and you have 3 of them in Down syndrome. Well, what we're actually studying is that in the triplicated chromosome, there's actually genes that are triplicated that actually are associated with the pathologies you find in Alzheimer's disease. And one of the therapies that we're currently testing in my laboratory, in collaboration actually with University of Arizona, is targeting one of those specific genetic triplications to see if it slows the progression of Alzheimer's disease. And we're currently in a preclinical phase, but hopefully the data pans out, we'll be moving to a clinical trial. So that's thank you for sharing that. And yeah, it's definitely an important area of research that's getting a lot of attention. Yeah. Okay, so let me go back to my presentation. Oh, bear with me. Okay, so it's not letting me move forward.
You
So
might
it's
have to stop it and start it back up. Sometimes it does that.
Yeah, it's not letting me start. It's letting me do that. Sorry about that. Okay. How's that? Does that work? Can everybody see this?
Let's back up. Yes.
Okay, great. Thank you. Okay, great.
Your notes are there too.
Your notes are there.
Oh, they are? Okay, well, let me do this. I think this does it. Is that good?
No.
Or it's still there? Or are the notes still there?
It
Yes,
is.
they're still there.
Okay, let me see. Swap. How about now?
They're
If
still
they are there, I mean, is that okay? I don't know
Yeah,
why.
we're fine with it. If you don't
Okay.
mind.
Oh, they're not. Yeah, they're not really notes. You can just see that it says no notes. Yeah.
Okay.
Okay, great. So thank you for that question. So what are some environmental risk factors? So we talk about Alzheimer's disease affecting individuals, and there really are a variety of different risk factors, right? Cardiovascular disease is one heavy risk factor. Mild life obesity, hypertension, and high cholesterol are all risk factors for Alzheimer's disease. Diabetes is actually a really, really significant risk factors. And when we think about the incidence rate, right, so we go back to African American and Hispanics having an increased prevalence of developing the disorder, they also have a higher prevalence of developing diabetes as well, right? So there's a commonality there in terms of risk factors for those specific group of individuals. There's actually evidence suggesting that lack of social and cognitive engagement, that is interacting with colleagues, friends, and not really engaging in cognitive tasks, can actually be a risk factor for Alzheimer's disease. Exposure to toxins, I talked about pollution, smoking, and excess alcohol can be a risk factor, and also traumatic brain injury. What the field has actually shown is individuals that are football players and also soccer players, and if they have constant blows to the head, can actually have an increased prevalence of developing Alzheimer's disease as well. Now, genetically, as I mentioned, there are mutations that occur in specific genes, right? And those mutations typically drive Alzheimer's disease in less than 5% of individuals affected. But the majority of individuals that have this disorder, over 95%, it's due to these environmental factors, and there's a risk factor, right? So a risk factor is different than a genetic mutation, because the risk factor means that if you have a specific gene copy, it increases your chances, but it's not guaranteed that you're going to get the disorder, right? And what you actually find is that there's one specific gene called the ApoE gene that if you have a certain allele, right? So you'll have various alleles, one you get from your mother, one you get from your father. If you have a copy of what's called the E4 allele, that actually increases your chances of developing Alzheimer's disease by threefold. If you have two copies, one from your mom and one from your dad, it increases it by 15-fold. However, that doesn't guarantee that you're going to get the disorder. So that's why individuals that have been tested and have an E4 are particularly encouraged to really follow a lot of brain-related promotion of health in order to avoid a lot of these risk factors as well. So they don't, since they have a predisposition based on this genetic factor, so they try to offset the disease as much as possible, okay? And now I want to get into, since we're getting to the latter part of the presentation, what are some things that we can do, right, in order to really promote this brain health and try to deter from disease? So one thing that I just want to really emphasize, I mentioned this again, while most cases of Alzheimer's disease are diagnosed after the age of 75, changes typically occur decades before. There's evidence suggesting that 30 to 40 years before you actually have the clinical symptomology, you can actually present with changes in the brain. So really, there's a variety of different lifestyle factors that can decrease the incidence of Alzheimer's disease, and these are all based on evidence, research, and experimentation, right? So it's all evidence-based. Here's a snapshot of what those are, and I'll talk about some of these today that I think are really critically important. But you can see things like exercise are very important for promoting brain health. Sleep is very important. Believe it or not, getting 7 to 9 hours, about 8 hours every day is very important, because there's things that happen to your brain during your sleep stages, which we'll talk about, that are really important to remove excess toxins and proteins from your brain that you don't want there. And having that lack of sleep really impairs the ability for that to happen. Diet, a well-balanced diet. There's one diet in particular that has shown very, very strong efficacy to offset disease. That's known as the Mediterranean diet. We'll talk a little bit about that. And also, mental health aspects, engaging with others in your environment, and really being social and having cognitive engagement, doing things like puzzles and strategies have been shown to deter from these diseases as well. So let's jump in and talk a little bit about diet, right? So the diet that has really shown a lot of efficacy in terms of slowing or even reducing the incidence of Alzheimer's disease is known as the MIND diet, M-I-N-D. And it stands for the Mediterranean Diet Intervention for Neurodegenerative Delay, And what it is, it's essentially a diet that's really based on the Mediterranean diet, but really includes including certain aspects of food in your diet, berries, for example, carrots, leafy greens, nuts, poultry, as well as fish is very important because they include many different types of nutrients and antioxidants that are really critically important for your brain, right? To reduce things like inflammation and to try to preserve that brain function throughout your life. And really the evidence has shown that there's a 53% lower rate of Alzheimer's disease for those that really engage on this diet by following all these different regimens, right? Pastries and sweets less than 5 times a week, try and avoid things like cheese and butter. You can have it, just not very frequently. And in those that do it moderately, they actually also found 35% less incidence of this disorder. Now, one of the things that's interesting about this diet is that it includes certain vitamins and nutrients that we know are very important for brain function and are also believed to protect the brain from by reducing inflammation, right? So there's certain nutrients that are needed every day by everyone, really. And a lot of us are not aware of that, right? And following the regimen of this diet allows you to get those nutrients. We'll talk about some of them in this next slide. And the one that I want to talk about is actually known as choline, which many people are not aware that it's actually very essential for various aspects of body and brain related functions. So choline is known as a B-like vitamin nutrient, and it plays a very important role in a variety of different things, protecting the brain health and memory. It supports heart health. We published a few papers actually showing this. It supports healthy liver function, prevents actually fatty liver disease, which can lead to metabolic disorder, things like diabetes and hypertension. And it's also important during fetal development. So women in particular that are pregnant are actually recommended to supplement with dietary choline, and I'll give everyone the numbers in the next slide of what those are. And we know that your body can actually produce some choline, but we also know that it's not enough for these bodily demands. So in 1998, the Institute of Medicine actually implemented recommendations for adult men and women and pregnant women on the amount of choline that they need to take for healthy body and brain related functions. And we can see here that those recommendations are as follow. So men are required to take 550 milligrams per day. Women are required to take 425 milligrams per day. And then pregnant women, because of the extra need for fetal development, if they're pregnant, are required to take 550 milligrams per day. Where do you find choline? In a lot of the foods that you find in the Mediterranean diet, right? So fish, poultry, eggs are known to have a high amount of choline. Beef liver, although a lot of people don't really like beef liver, but it has one of the highest amount of choline present. Things like wheat germs and kidney beans also have high amounts of choline. Now, if you don't get enough choline, because let's say, for example, through your diet, let's say you're a plant-based eater, so that eliminates your eggs as well as your beef and your poultry and your fish. There's actually supplements that are readily available that you can buy pretty inexpensively to get that recommended daily amount of choline that you need. And what's really daunting about all this research with choline, and I've been studying this for 15 years. We actually have a paper that's coming out in a very big journal in about 5 days here, and is that most Americans are not getting enough choline. It's actually known that 90% of Americans are deficient in dietary choline, and there's actually some countries that don't even have recommendations. So we know it's important. We know it plays all these important roles in brain and body related functions, but most individuals are not getting enough. So I really recommend, if I go back really quick, this website here. It's by the National Institute of Health and takes you directly to a consumer website where you can find all this information about the importance of choline. There's some of our research that's published there, as well as research from other individuals and how important choline is in order to really meet the demands of these body and brain related functions. And we actually have data from humans showing how critical it is and how it can actually increase the incidence of some of these pathologies, right? So we work with a banner in Sun City. There's a neuropathologist that we work closely with there who has various patients that have different phases of or at different stages of Alzheimer's disease. We were able to get some blood from these individuals, and what we find is that individuals that have Alzheimer's disease, considered moderate or severe cases, have lower circulating choline in their blood, right? And this suggests that they're likely getting less choline in their diet, and ultimately that can affect some of the outcomes, right? MMSE is known as mini mental state exam. It's essentially a score that assesses your cognitive abilities, things like learning and memory and attention. And what you find is that as the levels of choline go down, so does your score in the MMSE, right? And then if you look at things like brain weight, right? This is post-mortemly. So these individuals have passed away, and we take their brains for, they graciously donate them for science. We see that as the levels of choline go down, their brain weights are also significantly lower. And if you recall the image that I showed in the beginning where the Alzheimer's brain is typically smaller, you can see that those that have less choline have even smaller brains. So this really highlights that importance of choline supplementation that is needed every day, really, for everyone in order to offset disease. And we have quite a bit of evidence suggesting that those that are not consuming enough choline are actually seeing higher incidence of Alzheimer's disease. So something to really keep in mind. Exercise is definitely another example of something that everyone should be doing in order to really promote brain health. There are certain proteins in your brain that are known as neurotrophins. For simplicity, what they do is they just support your neurons. They're there to help the neurons function properly. And what's been found is that through meta-analysis is that regular exercise on a daily basis can actually decrease your incidence of developing dementia by 30%, which is pretty significantly high. And it's, I think that it's probably not surprising, because we know that if you exercise and you eat better, that reduces the incidence of you potentially having metabolic disorders like diabetes and hypertension and cardiovascular risk as well. So exercise is critically important. And for Alzheimer's disease specifically, because these are all other types of dementia, so Parkinson's and Lewy body, for example, it's actually 45%, so slightly higher reduction in the incidence of Alzheimer's disease. So one of the typical questions that you get is, well, what type of exercise is beneficial? There's so many nowadays, right? If you try to do a search on what exercise is beneficial, you'll find a lot. So really, it's a combination of aerobic exercise and resistance training. It's not doing one or the other. It's really doing both, right? So doing things like weightlifting, jogging, Zumba, water aerobics is very beneficial. For older individuals, water aerobics is a great way to exercise and elevate your heart rate and regulate some of the aspects of metabolic function. But it is has been shown that at least 6 to 12 months of exercise is really necessary to detect changes in brain function, right? So it's not just exercising once or twice every two to 3 months. It's really consistently having a regimen of these exercises in order to show these beneficial effects. And how much? It's recommended that you get a minimum of 150 minutes per week, right? So that can be broken down into 30 minutes a day or every other day, depending on what your schedule allows you to do. But there are reports that have shown that 6 to 10 minutes every day is already somewhat beneficial and could have potential effects in reducing the incidence of dementia and Alzheimer's disease. So exercise is really, really important. And sleep. Sleep is one of the things that typically or constantly gets underlooked. It is critically important for brain health. And why is that? If you look at this graph here, I know it can be a little complicated, but bear with me. These are waves, right? And this is through a recording that's known as an EEG. And what essentially that does, it just monitors the activity of your brain, right? Is your brain active? What you find is these stages here, stage 1, 2, 3, 4, and REM, are all stages of sleep. So you're asleep. And you can see there's still activity going on throughout your brain, right? Your brain is still active, but you're not awake, right? I mean, you're not conscious at that point. You're you're asleep, and you typically don't get up and move unless you have a disorder known as somnambulism, which means you get up and sleepwalk. But typically you are not able to move. And what's happening during these stages is really important, because there's a lot of cleaning and removal of waste in your brain that's critical to allow you to have the next day and be able to function properly, right? And what has been found is if you don't have these adequate stages throughout the 7 to 9 hours of sleep throughout every night, that can actually start to compromise your neuronal function, ultimately your behavior. I always tell my students that they need to make sure they get a good night's sleep before an exam, because if you cram and then you don't sleep, you're very likely to do worse, because the brain is also the sleep is also very important for consolidation of memories, right? There's evidence on that. So during sleep, a lot of your memories or a lot of the experiences you have during your day get consolidated or get turned into memories. So if you disrupt the sleep, or if you don't have sleep, then the next morning it's much more difficult to remember things, because your brain hasn't properly been able to put those into memory storage, right? So that's very, very critically important. And 30% increased dementia risk if you do not sleep at least 7 hours of sleep has been shown, right? So everyone should be getting adequate sleep, and know that this actually does have significant effects, and also that during sleep, your brain is still active, right? You're just not consciously aware, and you're paralyzed at that point, and that's why you're not able to move. Yeah. And here you can see this nice example of a imaging technique that they used, that researchers use. And this is the activity of some fluid that is going through the brain, and it's getting rid of all these toxins and proteins that don't belong there, right? And this is happening during the sleep phase. So this individual is asleep, and you can see that there's this washing of the brain essentially that occurs. If that doesn't happen because you're not getting proper sleep, then that trash or that unwanted protein is going to accumulate and begin to essentially harm your neurons and neuronal function. So I have one slide left, and then I'm more than happy to take any questions. But one of the really interesting aspects of how we know this works is really tied to what are called blue zones. So here you can see a map of the world, and you can see all these different locations, right? These 5 different locations throughout the world. And what's unique about them? Well, what's unique about them is that life expectancy is higher than what you see in other countries. And secondly, there's no incidences or very little incidence of dementia and Alzheimer's and other disorders in these regions. So why is that? Well, it is known that in these what are called blue zones, individuals typically engage in a diet where they grow their own crops, where they're engaging in eating things that are more leafy greens, berries, antioxidants, things of that sort. They have smaller communities that they interact with and socialize with. There's less transportation of vehicles that require gasoline, so there's less air pollution. And in these specific zones, you see individuals live longer. So we are trying to learn from these blue zones, what are they doing, and how do we map that into our other parts of the world to try to mimic some of their success in terms of living longer and living with less incidences of dementia and Alzheimer's disease. So with that, I just kind of want to conclude and say that I hope you are convinced that these various aspects of our lives are critically important, not only for our peripheral body organs, but really in our brain, and really play a big role in reducing the incidence of these disorders that happen later on in life. And since we're seeing really a high incidence of these disorders that are occurring, and since individuals are living longer, it's really critically important to encourage individuals to engage in these specific types of activities in order to really offset themselves from these neurodegenerative disorders. And with that, I'd just like to have an acknowledgement slide. So these are all the universities that I currently collaborate with throughout the United States, and here in Arizona specifically, TGen, Mayo Clinic, Banner Health, Bioneurological Institute, and University of Arizona, and also University of California, Irvine as well, and our funding sources. And you can also see my little QR code here if you'd like to scan it to learn more about our research. But with that, I will stop sharing. And if there's any questions, more than happy to take them. Thank you. Yes. I see one hand up or two hands up. I'm not sure I'm pronouncing. Is it Yvonne?
Yes, that's Yvonne.
I,
Yeah, I'm just wondering about autistic people. You did mention some of the effects of lack of social and also, activity and stuff, can cause some issues. But with the autistic or autism people, how do you manage preventing Alzheimer with them? Because I do know that statistically, I read somewhere that autistic people don't get Alzheimer till they're about 70, 65, 70.
right.
And but if a lot of them don't have the social skills, like Elon Musk. I mean, he admits it that he
Right.
has it, that he doesn't care. But how do you monitor that or trying to have people get Alzheimer like autistic?
Yeah, that's a great question. So we actually have a group here at ASU that are studying those aspects. So they're following individuals that have autism, and they're seeing, you're absolutely right, that there is incidence of Alzheimer's disease at about 70 years of age in these cases. So we're aware of that. There's actually programs that are being set up by ASU here. The person that runs that program, her name is Dr. Blair Braden, and she's very well known for her autism research, where she actually tries to get individuals to come in and interact with each other that have autism in such a way to really allow them to engage in that social and cognitive aspect. But being that it's autism, we understand that that's a main driver of, I mean, that's what happens with that disorder, right? Social engagement is very difficult. So they actually have all these different other techniques they're trying. So they're doing things like mindfulness. They're encouraging things like yoga, group yoga, things of that sort, and they're actually finding pretty good success. So I think, to answer your question, it's finding ways in which you can still get aspects of brain function or promotion of brain health to occur, even though individuals, are obviously going to be affected with the inability or potential inability to interact with others, right? And that's why they're engaging in things like mindfulness and breathing exercises and yoga and that sort of thing. Yeah. Charlotte, I see your hand up.
Yeah, I had a question. Is a vegan diet also good for brain health, similar to the Mediterranean diet?
That's a good question. I actually wrote an article about this about 2 years ago, because what tends to happen when you reduce things like poultry and fish, you lose a lot of nutrients, like things like omega-3s, choline, for example. So while there's benefits to the vegan diet and to the, plant-based diets because of things like cholesterol and those sorts of things, it's really recommended that for those individuals that engage in that diet to make sure that they're also potentially supplementing with other specific vitamins and nutrients or a multivitamin on a daily basis to get the actual nutrients and vitamins that they need that they don't get from actually eating meat products. Yeah.
I have another question.
Sure.
How do you mentioned choline?
Mm-hmm.
How can you find if you're getting enough of that? Do you get a blood test for that, kind of the same way you do for vitamin D's and everything else? Are you able to gauge it through a blood test?
That's a great question. That is something that we as choline researchers are incredibly frustrated with, because it's not something that's part of a panel. We're trying to push it so it is part of a panel. But there's the way that it's really gauged at this point is doing surveys and questionnaires and seeing what type of food you're eating. Let's say, for example, that you map out, okay, this is the type of food I ate for a week. and you get an estimate on the amount of choline that you're actually taking based on that, right? So you can request it through your provider, but it's not typically offered, and it's not as streamlined as like getting a CMP or getting a CBC, right? So it might be a little difficult to get it, but if you can request it and they could find a way to do it, that'd be great. But really the way to do it is to sit down and map out, okay, what did I have for a week? Which foods actually contain choline? And that's why it's actually recommended that even if you are, let's say that you map that out and you're getting 250 to 300 milligrams per day, that's why supplementation is recommended, because it's not going to harm you. And in fact, we have data suggesting that if you supplement with more than the recommended daily intake amount, it can actually be much more beneficial, right? So that's why we recommend that even if you're eating the 550 milligrams per day, if you were to take a supplement that gets you to 800, that would be fine, and that would ensure that you are getting adequate choline. Yeah.
There was another question in the chat that says, is allergy medications, including Benadryl, known to increase risk for dementia?
That's a great question, and that's a conversation that I've recently had with a physician. I don't know the exact science behind it, so I'm not going to make strong statements, but there is some evidence, correlational evidence, right? So correlation, it doesn't mean causation yet, or does it? It hasn't been proven, but there is some evidence that specific drugs like Benadryl can actually increase slightly your incidence of these dementias. Yeah, that is actually known, and it's in the literature. But once again, it's correlational, right? So it's not like they've done a study where they give individuals Benadryl and then they measure the outcomes 30, 40 years from now, right? So it's more of, hey, these individuals were exposed to Benadryl and they're for some reason showing increases in incidence, but it's very hard to control because there's so many factors that can play into that, right? But to answer your question in a simple way, there is some evidence that it can potentially, yeah.
Okay, I just have one more question.
Sure.
You talked about the diet, and a lot of our tribal ALTCS members are Native American members.
Right.
So in indigenous foods that some of our members do have or do grow, I know that a lot of them have sources to beans or have sources to some type of whole grains, nuts, and seeds. Do these contain choline?
Yes, they do. So beans do, and grains definitely do. However, if I go back to the slide, I don't think I can. I'm not going to try, but there's actually they contain a little bit, really. Where you find a higher amounts of choline are in specific products like eggs. Eggs has really the highest amount of choline. If you for example consume 3 eggs a day, you're getting what you need in terms of recommendation or choline. So beans and vegetables and leafy greens have choline, but you would have to eat quite a bit of leafy greens and beans in order to get the recommended daily intake amount. That's why it's recommended for plant-based eaters to look into supplementation of choline via over-the-counter vitamins or multivitamin as well. Yeah.
All right, thank you so much.
No problem.
I believe that was all the questions that we had in the chat, and it doesn't look like anybody else has their hands raised. So I really do thank you for the presentation that you have provided to our tribal long-term care program. As you know, this is a long-term care program, and many of our members are actually, you know, have this diagnosis and have family members that, you know, care for them in the home. And the reason why we wanted to bring your presentation to this group is that they can provide a little bit more education, or maybe network within their tribal their tribal health plans, or their tribal healthcare organization, to maybe reach out to those other organizations and provide a little bit more support, or you know, get some sort of more information that they can share with the members at their level. And
Right.
pretty much that is the reason why we wanted you to present. I attended the presentation you've done here at Access, and I was very impressed. And I said, yeah, we do hear a lot, and sometimes we don't understand, or family members don't understand. And I think it's a lot more education for our case managers to be able to take this with them and have a little bit of knowledge about it. And if they want to research further, you did provide your information, so that would be really helpful too. So I really, really appreciate your presentation. Thank you so much.
Yeah, no, thank you for having me. And if there's any questions that come up, you know, after this presentation and you'd like to reach out, if you have that QR code, it takes you to my website and you can find my email and email me directly.
Awesome.
All right. Well, thank you so much for inviting me, and everyone have a great day.
Yes,
You
thank
too.
you. Great presentation. Thank you.
Thank you so much. Bye-bye.
Bye-bye.
So that concludes our Tribal ALTCS quarterly meeting. That was a lot of good information. I mean, I know culturally we're kind of used to certain ways of doing things with our family members, the way we were raised. I know there are some tribes that don't eat fish, and that I kind of thought about that as he was going through the list of the diets and stuff like that. So, but it was a really good presentation, and you guys can feel free to reach out to him if you feel like this is something that you want to maybe train your case managers on. And of course, they can always, like I said, they can review the presentation that's recorded to get a little bit more information, and that can help to provide some sort of education, not only for the family members to understand, and maybe even the members who are in the early stages to understand. It really does help, or even just referring them to, wherever they get their healthcare services at, and ask more questions and not to be afraid. So that's why we wanted to bring this here. And of course, as always, we bring stuff to this quarterly meeting to kind of touch up on areas that your team could be struggling with. Some of these presentations may be redundant. I mean, we have to go over it and over it again. We're actually going to go through all of our archive, our presentations that are also online, and see if we can come up with some sort of cheat sheet to where we can just refer you to. And for those of you who struggle in some areas of processing a certain type of request, or needing assistance on a service, or providing provider education at your level, or getting more information, you can always go back to these presentations. And we encourage you to share it with your team, to your case managers, because they're the ones who are coordinating services. They're the ones who are doing the face-to-face. They're the ones who are entering the services in the service plan and PMMIS, all the screens. So, and sometimes, as for new leader, don't be afraid. There's always that you have really good case managers at your level. They know the system very well. They're familiar with it. They can also provide you that assistance if you need it. We have policy manuals that we reference you to, and also we have the AMPM policy, or the AMPM manual. You can not the AMPM, PMMIS manual online too, so that you're able to kind of self-navigate and learn that, which is pretty much what my team has utilized. We didn't get that one-to-one training, unfortunately. We kind of had to learn as we went, and that PMMIS manual, that's where I learned everything from. So please utilize that as much as you can to gain all the knowledge that you can from it. You can learn it. If I can learn it, you all can learn it. And a lot of things that you guys do is amazing. Your team is, I'm always impressed by all the case managers. And whatever we can do to advocate for the program, whatever we can do to make things a little bit smoother and easier. As you've seen, there's a couple of changes that we're putting out there, the new forms, the extensions of the PA in certain circumstances. We've been really advocating for that. Vanessa has really spearheaded that portion of it, advocating for you all and saying, we should look at this, we should consider this. Even on Sani's side, you know, she's really always helping. Her team is helping to create forms to make things easier for you and your staff. And we try not to make it too hard to where if we can simplify something, we do the best that we can. So if you guys have any ideas too, this is your program. If you have any ideas or suggestions, always feel free to send them over to us, because then we can review it. We are testing certain things with one of the program who stepped up and said that they'll be the candidate to kind of test one of the things that we're doing right now. And I believe they're doing an awesome job, which once we see that it's running smooth, we're going to transition it over to introduce it to different programs slowly, not just throw it out there. So we're trying to, like I said, you know, we're not the ones who know everything. We don't know everything. You know, we do our best to teach you what we know. We want you to know what we know. And we're not the one who says you're doing it wrong, you're not doing it right. I always want you guys to feel comfortable that if you don't know something, it's okay. You know, let us know your level of knowledge and we can go from there. So it's always open. We do have an open virtual meeting office for you all. Always don't hesitate to reach out to us if you need assistance with anything. So thank you very much for attending. We appreciate it. I believe Charlie had attached something here to document your attendance here. We want to make sure that you're noted here. So in the event that one of your team members are calling us, or if we have to walk you through a process that we've trained on, we know we'll always try to say, hey, you attended that training, what's going on here? So we just want you to make sure that you're accounted for in these meetings also. So thank you so much for attending. You all have a very great day. If you're traveling, safe travels back to your offices.
Yes, thank you very much.
Have a good day.
Thank you, everybody. Have a great day, and thank you for all you do.